Welcome to our live webinar titled MDS and High-Risk MDS Treatment Strategies. Thank you for joining us today. My name is Lee Clark, patient educator with the Aplastic Anemia and MDS International Foundation, and I'll be moderating the presentation today. As we get started, we recognize the generous support of Bristol Myers Squibb, Agios, Jazz Pharmaceuticals, Genentech, and Takeda Oncology, as well as the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit any questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share any private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Michael Keng, who holds a clinical faculty appointment in the medicine in the Division of Hematology Oncology at the University of Virginia Cancer Center. He practices at the Couric Clinical Cancer Center in Charlottesville and serves as an inpatient hematologist at the University of Virginia Hospital. He attended medical school at Michigan State University in East Lansing and completed an internal medicine residency at the University of Southern California in Los Angeles. He completed a fellowship in hematology and medical oncology at Cleveland Clinic in Ohio in 2014, where he served as the chief fellow from 2013 through 2014. With that said, welcome Dr. Keng, and thank you for joining us today.
Hi, thank you so very much for allowing me to speak. This is such an honor, and my topic today is on myelodysplastic syndromes. I know that the topic was specifically higher risk myelodysplastic syndrome, but I'm going to give a little bit of an overview and update initial approach to myelodysplastic syndromes, and then touch base on higher risk myelodysplastic syndrome. There is a lot of information to cover. My slides will be made available, but I will not likely be able to cover every single slide to the detail that I would like. If there's any questions, feel free to reach out in the question and answer box or through the Aplastic Anemia MDS International Foundation, and they can maybe filter questions back to me. My slide here just shows my disclosures. I served on the Physician Advisory Board to Agios several years ago. Next slide. So the objectives today are as follows. We want to figure out what are the initial symptoms and things to recognize for myelodysplastic syndrome. What are the initial approach to cytopenias or low blood counts? And then we want to understand how do you make the diagnosis and how do you understand the prognosis of myelodysplastic syndrome? And then a bit about treatment and supportive care for patients undergoing treatment for myelodysplastic syndrome. Next slide, please. So this is the overview of where we're headed. We're going to start off with symptoms. Next slide. All right. So many patients ask me, what should I feel with the diagnosis of myelodysplastic syndrome? What I often tell patients is that many patients are asymptomatic. That means they don't have any symptoms. Most of the time, patients actually present to their primary care doctor and just said that they're here for routine follow-up and just screening. And then routine labs just show that they have low blood counts or cytopenias. That's about half the patients. The other half present with symptoms, and they're likely due to the low blood counts. So some patients will say that they have fatigue, which means that they're tired. They may be short of breath or have heart palpitations because they have anemia. Anemia is low red blood cells. Now, some patients with neutropenia or low white blood cells may have problems due to that, namely fevers, recurrent or prolonged infections. Infections that just keep on occurring over and over again when most of the time in the past they have been able to get rid of that infection quite easily. Thrombocytopenia or low platelets can lead to bruising, petechiae. Petechiae are certain bruising, that's little red dots that are on the actual skin itself. That's the medical term for bruising. And you can have bleeding. And bleeding could be anywhere. It could be from the nose, the mouth, or just even in your GI tract, which is your large or small intestine. So when you go to the bathroom, when you have a bowel movement, there could be blood or dark stools. Next slide. So those are the symptoms. Now we're going to talk about what happens when you have cytopenias or low blood count. Next slide. So this is the general overview. We're going to break this up step by step. But in summary, we're going to just start off with symptoms of cytopenia. And if you have a symptoms for cytopenia, how do we work that up? We will have to look to see if you have a patient history that's supportive of myelodysplastic syndrome. If you do, and there's high enough suspicion for myelodysplastic syndrome, this is when a patient should be referred over to hematology oncology. However, if you do not have a clinical history supportive of myelodysplastic syndrome right away, the primary care physician or a referring physician may think about doing the workup for the specific low blood counts, whether that's anemia, neutropenia, or thrombocytopenia. And then if there's still low suspicion for myelodysplastic syndrome, you treat the underlying cause. If there's something that's persistent, then you would want to continue the workup for myelodysplastic syndrome. Next slide, please. So symptoms. So how do I define, sorry, you can move over. Thank you. So how do I define cytopenias? So cytopenia, what I look for is hemoglobin. If your hemoglobin's below 10 or 11, then that's something that would get me thinking about low hemoglobin or anemia. A and C is the absolute neutrophil count. So if that certain type of white blood cells, the neutrophils, are below 1,500, then that's something that should trigger something to move forward with a workup. Or platelets. If platelets are less than 100, then that is the definition of cytopenias in my book. And this is all pretty standard in the United States. So the initial workup is going to entail a complete history and physical. Your physician would need to figure out, are you currently ill? Are there any current symptoms that are that you're dealing with? And to figure out your medical history and other potential causes of cytopenias. A physical exam could be helpful. You want to make sure that in addition to considering a myelodysplastic syndrome as a potential diagnosis, physical exam could be helpful. For example, if you have an enlarged lymph node or an enlarged liver or spleen, that can potentially point you to other diagnoses. A peripheral smear is what's shown on the right-hand side of the screen. What you do is you literally take a drop of your blood and of a patient's blood, and you drop it on the slide, and then you put it on a glass slide, and you smear it, and that's the term peripheral smear. And you want to look for these specific cells to see if there's any differences in them. What you want to see, hopefully, are just normal cells, normal red blood cells, normal white blood cells, and normal platelets. However, if there are abnormal cells, like the ones with the red arrow pointing to them, that's something that we call dysplasia, or cells that look funny under the microscope. You need to have a minimum of 10% of this dysplasia for us to say that you meet the definition of myelodysplastic syndrome. Next slide. So that's the symptoms of cytopenia. And now, what is the specific clinical history that we're going to be looking for? Next slide, please. So the clinical history that we are going to be asking as an oncologist is, number one, do you have a history of chemotherapy, radiation therapy, or are you currently on immunosuppressive medications? Did you have a history or significant exposure to chemicals? For example, did you work in a metal or a chemical plant and did not have proper protection in that you have direct contact to those exposures? Do you have a congenital or family history of bone marrow disorders or specific cancers? And lastly, if there's multiple cytopenias, if there's anything that looks funny under the microscope, which we talked about, which is on that blood smear. Next slide. So what I already said so far is, depending on the history, if those questions that I answered were yes, then you probably have a higher suspicion of myelodysplastic syndrome. Then you want to just be referred, a patient should be referred over to the hematologist and oncologist office directly. However, if it's no, there are specific reasons that can cause the low blood counts of anemia, neutropenia, and thrombocytopenia, and that's on the next slide. So neutropenia are low white blood cells, and specifically the neutrophils. Certain nutritional deficiencies, autoimmune disorders, and medications could cause neutropenia. Thrombocytopenia, or low platelets, can be caused by a variety of things. You can have specific inherited platelet disorders. You can have things that are developed halfway through, so not from that's not genetic or passed on, that occurs later in life, like immune thrombocytopenia in the purpura, that's ITP. There's certain things that associate with infections, such as like disseminated intravascular coagulation infections. They can all cause thrombocytopenia, and definitely medications can as well. Now, on the right-hand side of this slide, it lists anemia, or low red blood cells. There are many different types of anemia, depending on the different sizes of your red blood cell. So microcytic just means that your red blood cells look smaller than usual. Normal cytic means that the red blood cell volume is the same as what normal should be. And macrocytic anemia is when the red blood cells are larger than what you would expect. The reason why I'm differentiating between this is that as a primary care physician, your primary care doctor needs to go through each one of these to figure out what meets the criteria the most. Now, for myelodysplastic syndrome, most typically, patients will have a macrocytic anemia, so a larger red blood cell volume than normal. And they can obviously have neutropenia or thrombocytopenia. If you notice, medications is a common problem, and even infections is a common problem for all of this. So medications and autoimmune disorders and infections can lead to these low blood counts. So that's why having low blood counts does not automatically mean that you a patient has myelodysplastic syndrome, but it's part of the workup and needs to be considered. All of these can be treated by a primary care physician and does not need to be seen and referred directly to a hematologist oncologist. Next slide. So let's just say someone actually has been ruled out and is now concerned for the diagnosis of myelodysplastic syndrome. We're moving on now to epidemiology and staging. Next slide, please. So this is the very medical term of myelodysplastic syndrome, and I'll break this up after I read it. Myelodysplastic syndrome is a heterogeneous clonal hematopoietic disorder derived from an abnormal multipotent progenitor cell. So it is characterized by a hyperproliferative bone marrow, dysplasia of cellular elements, and has ineffective hematopoiesis. So I understand that's a really big mouthful, and so my next few slides we're going to go over what that means. But most importantly, what I do want to stress is that myelodysplastic syndrome is often called in colloquial terms as a pre-leukemia state. It definitely is the step before leukemia. However, it is not a something to just ignore. Myelodysplastic syndrome is definitely a cancer of the stem cells. Next slide, please. So let's kind of go through what my previous slide talked about. Let's break them up. So what happens in myelodysplastic syndrome? Number one is that cells look abnormal. They have different shapes and sizes. So that term is dysplastic in medical lingo. Now, hematopoiesis means when cells don't work well. So, sorry, hematopoiesis is when normal cells go from stem cells to red blood cells, white cells, and platelets. When that doesn't work well, then that's ineffective hematopoiesis. And then this all results into cytopenias, and we already define that as low blood counts. Eventually, there is a risk of this developing into frank leukemia, and that will happen when the bone marrow function eventually declines. Moving forward, I think what we really need to stress here is that myelo just means the specific types of stem cells that we're dealing with and proliferative disorders. So now, moving forward here is what we're looking at is a healthy bone marrow cell. So this bone marrow is made in the middle of our bones, and so what normally happens is that we have this cell called the hematopoietic stem cell. It then goes to multipotential stem cells, and then they can go to lymphoid, and then they could go to myeloid progenitor cells. And what we are most concerned about are the myeloid progenitor cells, because they can be leading to the low counts that we are most concerned about, which are the neutrophils, the basophils, eosinophils, monocytes, platelets, and red blood cells. When these are low, this is something that we are most concerned about, and we need to we need to get further workup. So, can you get to the next part? Yes. So when things happen intrinsically and extrinsically, they can lead to defects into this normal process. So intrinsic means something that happens within. So this is within your actual body itself, meaning that there could be a gene disorder or gene problem. So like if this is something that is inherited from something, from your family, for example, or extrinsic, meaning that something outside your body caused a defect. So extrinsic factors could be previous chemotherapy or radiation therapy. So when these factors hit this bone marrow and causes an abnormal cell, they could create immature precursor cells. And these immature cells can mutate and can continue to develop more and more and more. And when that happens, that leads to peripheral cytopenias or low blood counts that we see in the complete blood count. And that can lead to a hypercellular bone marrow because there's more cells now inside your bone marrow. Next slide. All right. Next here. This talks about the epidemiology of myelodysplastic syndrome. The median age that occurs is 71 years old. This occurs slightly more in men than women, and most myelodysplastic syndromes are primary in nature, meaning that it just occurred, not secondary to something else. Next slide. So this slide is borrowed by, from Dr. David Steensma. He is a colleague of mine that works out of Dana-Farber in Boston, and he nicely has this pictorial of the different subtypes of myelodysplastic syndrome and kind of where it comes from. So what we talked about, de novo, it's just something that occurs. It occurs just naturally with aging. So what we said was that 85% of patients have this, de novo subtype, and it occurs around at 71 years of age. Now, the other remaining portions comes from a secondary cause, and they're listed right here. So 10 to 15% of patients can have ionizing radiation or some sort of chemotherapy called DNA alkylating agents. These specific patients don't have myelodysplastic syndrome that occur right away. They have a delay. So for example, some patients with breast cancer, this specific chemotherapy that they receive will cause a delay in their low blood counts and potential having myelodysplastic syndrome, and that delay may be 5 to 7 years after the initial exposure. Now, less than 5% of patients will, that will develop myelodysplastic syndrome have a history of topoisomerase II inhibitors. This is another specific chemotherapy, and this leads to much faster leading to myelodysplastic syndrome, and this usually occurs within 1 to 3 years. Next slide. All right. Let's see here. This slide talks about how complicated these bone marrow disorders really are. We all remember Venn diagrams as a kindergartner, and usually Venn diagrams just only have 2 circles with an overlap. But this one, you could see there's multiple circles here, and they all have different overlaps with myelodysplastic syndrome. So all these specific types of bone marrow disorders can have the same symptoms as myelodysplastic syndrome. So what's really important to do is to go through that physical, that history, and that workup very carefully. And the workup is something that we're going to talk about in the next few slides. Next slide. All right. So this is a workup that's recommended by the National Comprehensive Cancer Network, and this is as of February of 2020, this year. And what this says is these are things that a hematologist needs to consider when doing the workup for someone that there is concern for myelodysplastic syndrome. The biggest thing is that you need a history and physical and blood work, and you need to rule out all these other diagnoses that we talked about before. So on several slides ago, when I went through all the things that could cause low blood counts, those are the things that a hematologist needs to make sure have been already evaluated for, and that has been able to know that these are not the reasons for the low blood counts before just assuming it's myelodysplastic syndrome. One thing that does need to happen is a bone marrow biopsy, and we're going to be talking about that in the next few slides. Next slide. So for myelodysplastic syndrome, you will need a bone marrow biopsy. Now, a bone marrow biopsy includes the aspirate and the biopsy portion. So the actual aspirate is the liquid part of the bone marrow, and the biopsy is the solid portion, the core that's maybe referred to. Now, so what is important is that we run specific tests on the bone marrow in the aspirate and the core biopsy itself. The bone marrow is where all these stem cells are actually housed, and if there's any abnormalities, you're going to see it in the bone marrow first before the blood. And so, though we may see some abnormal cells in the bloodstream, a bone marrow is going to be more helpful because it's going to be able to allow us to look specifically in the bone marrow and to do specific testing. We're not only going to look at what the cells look like and count how many dysplastic-looking cells there are, but we're going to be running specific tests. We're going to be running genetic tests. We're going to be looking to make sure that there are not leukemia blasts. Those are leukemia cells that need to be allotted for and accounted for. And the specific genetic tests we're going to be looking for are chromosomes and gene mutations itself. Other things that we'll need is a complete blood count, and that is just the CBC, and we already talked about that. And the karyotype is the chromosomal analysis. All right, next slide, please. All myelodysplastic syndromes are not the same. In 2016, the WHO, or the World Health Organization, had reclassified MDS. And these are the specific subtypes us hematologists are looking at when we talk about and thinking about myelodysplastic syndrome for some of our patients. So the specific subtypes run from with single lineage dysplasia all the way to excess blast 2, and there's specific ones that are there. To be very easy to think about things, most patients with single lineage dysplasia, this first row, and ring sideroblast typically are considered lower risk. Most multilineage dysplasia could be lower risk to intermediate risk, and excess blast 1 or 2 are more considered higher risk myelodysplastic syndromes. And I'll explain what that risk actually means and then in the next slide. But there's some unclassifiable myelodysplastic syndrome types that look like myelodysplastic syndrome, but doesn't fit into any one good category. And then there's one myelodysplastic syndrome that has an isolated deletion 5q abnormality. This is important because we have a medication called lenalidomide or Revlimid that is very effective in this setting. So you could see for these specific subtypes, we need things to be matched in the blood and the bone marrow in order for us to talk about and meet the definition of myelodysplastic syndrome. Next slide. All right. So the best prognostic scoring system that we have right now is something called the IPSS-R. This was done by Dr. Greenberg published by Dr. Greenberg in 2012. And you can see that this is a little bit old already because it's 2012. But this is the thing that's most validated and what we use for clinical trials the most. So in the IPSS-R, we have different parameters. We look at a patient's cytogenetic, which will be explained on the next page. That's the DNA chromosomal mutations. We look at the bone marrow blast proportion. The blasts, like I said earlier, are leukemia cells. So the less leukemia cells, the better. And we look at each cytopenia, the hemoglobin, the platelet value, and the neutrophil value. And obviously, if you have more degree of severity of the cytopenia, the worse that is. And you want to add that up. The lower the score, that would be better, and this ranges from a 0 to 10. Next slide. This slide will explain the different cytopenias. Now, the cytogenetics. And so the cytogenetics or karyotype is when we take a bone marrow sample and we actually grow it out for chromosomes, and we look under the microscope and we actually try to figure out what mutations there are. Some mutations are good, and that's listed here in the very good column, and there are some bad mutations. And if you have a lot of mutations, meaning greater than 3 abnormalities, then that's the very poor column. And so this is important because the more abnormalities that you have, that does potentially affect your overall survival and things that you need to consider about for treatment. Next slide. So once you add up everything, you can, as a patient, can go from different risk groups from very low to very high. So, and that's all based on that point system that we talked about 2 slides ago. And you can see here, if you're under the low risk group, you can have a median overall survival for a patient, 8.8 or so years. Now, there are patients that belong in the very high risk group, and the median overall survival, meaning how long a patient may potentially live, is a lot shorter. And then the very right-hand column describes the percentage of patients that may develop into acute myeloid leukemia. I must say, though, that this is older because this is all based in 2012 data. We have a lot more medications that are that has come out. We have more clinical trials, and we have different thought processes on how do you look at specific genes that are not even listed in this scoring system. So I list this out because this is what patients bring to my clinic and ask me about, and so I want to address that. But this is outdated, and we don't have a better scoring system quite yet. Every year there's new ones that are brought up, but not one has been formally adopted from all of us. Next slide. All right. So I already talked about some of the limitations to this, that only half of the patients have relevant cytogenetic abnormalities, meaning that 50% of patients have other cytogenetic abnormalities that we don't know what to deal with, and it's not part of the system. There's a lot of heterogeneity, meaning that there's a lot of diversity with each category. Not all patients in the very low risk group are the same, and not all very high risk patients are the same as well. And so it lumps patients together, and that could be very difficult. This excludes patients that are therapy related and patients with chronic monomyositic leukemia. This is only validated, the scoring system, at the time of initial diagnosis in an untreated patient. When patients have gotten treatment, you cannot just keep on reapplying this prognostic scoring system. And like I said already, this does not include the newer genetic mutations that we are able to obtain right now. So we are looking at this from a community perspective on how do you best work on a newer, better scoring system. Next slide. Now we're going to switch over to treatment of myelodysplastic syndrome. Next slide. So I'm going to talk about a few key principles of myelodysplastic syndrome before diving into the specific treatment. Now, myelodysplastic syndrome in itself is not curable with standard chemotherapy. The only cure that remains right now that we have is through an allogeneic stem cell transplant. That means taking someone else's bone marrow stem cells and giving it to a patient with myelodysplastic syndrome. Though myelodysplastic syndrome is not curable, we can still get very good responses to patients with myelodysplastic syndrome. And so what we're aiming for are hematologic improvement. Sometimes stable disease and decreasing transfusions are very good things that, as a hematologist, we want to strive for. Next slide. So what are the goals? What we want to look for is that treatments used to be only focused on improving the blood counts, improving transfusions, and delaying time to leukemia transformation. Now, we want to keep all of those same things because those are very important factors that we want for our goals, but we want to also include the following to improve overall survival so that patients can live longer, but not just to live longer, but to live longer with a better quality of life with very minimal toxicity. Next slide. Okay, so some other key principles are that age alone is not a factor that precludes or excludes someone from active therapy. Blood counts will often get worse before they get better, and I cannot stress this enough. I always have to remind my patients that your counts will get worse, meaning that you may feel a little bit worse before things get better. Most myelodysplastic syndrome treatments require time before they actually most active therapies for myelodysplastic syndromes require time before they work. So we can't just do 1 to 2 cycles and then evaluate with another bone marrow biopsy. What needs to happen is that patients need to be evaluated after more treatment, meaning 4 to 6 months or cycles worth of treatment. So it's not something for the faint of heart. It has to be, you need to have patience when going through this treatments for myelodysplastic syndrome. Now, the strategies, what we want to do is to manage side effects in the early phases so that we can obtain the best response. Next slide. Okay, so again, my whole seminar today will be mainly focused on the higher risk treatments, but I don't think it would be great if I just ignored all the other different types of treatments that are out there. So there's one slide just tries to go over different treatment intensities from the least intense to the most intense. So I listed that from top to bottom. So if patients have lower risk myelodysplastic syndrome, things that you can consider are things such as observation, and then in order of severity that goes to growth factors, blood transfusions, lenalidomide, luspatercept, immunosuppressant, hypomethylating agents, and then finally stem cell transplant. Because luspatercept was just approved this year, I have a few slides to talk about that, though it's not geared for higher risk patients. And then I'll be focusing the majority of my time on the hypomethylating agents and some clinical trial data that has just come out. Clinical trials, in my opinion, and most oncologists' opinion, are always the best options to consider because they allow patients to have therapies that are not otherwise available. Next slide. So I have this slide for both lower risk and also higher risk settings. This was a paper that was published by Dr. Sekaris and Gurridge from the Cleveland Clinic back in 2014. So what this allows you to follow is an algorithm for a patient with lower risk myelodysplastic syndrome. I have one that's higher risk. And just for the sake of timing, what we're going to be focusing on for lower risk are mainly just observation, growth factors, or lenalidomide. These are the major things to think about when you have an isolated cytopenia. When you have multiple cytopenias, things that you want to think about is something like immunosuppression therapy or hypomethylating therapy or a clinical trial. Next slide. So what I do want to spend some time on is luspatercept because it was just approved. So luspatercept is a medication that was used for patients with very low or intermediate risk of myelodysplastic syndrome. This was led by Pierre Fernal from the UK, and this was presented by Dr. List from Moffitt Hospital in Tampa, Florida. And this is the Medalist trial. And so I'm going to be talking about that. Next slide. So Dr. List presented this back in 2018. The rationale is that there are patients with lower risk myelodysplastic syndrome that can have a poorer prognosis. These patients are ones that actually need red blood cell transfusions, and the more transfusions that you need, you can run into more problems, such as iron overload or secondary organ complications. And prior to this point, we didn't have anything as hematologists to offer patients with this lower risk myelodysplastic syndrome other than growth factors and blood transfusions. Next slide. So what is luspatercept? Luspatercept is a first-in-class erythroid maturation agent. It basically goes into your cell, it signals your DNA in the bad myelodysplastic syndrome red cell to make more mature red cells. So what we're finding is that potentially in some settings, red blood cells are not being produced by the body because it's not getting the right signal. And so luspatercept hopefully will allow our bodies to make more red blood cells, and that's the mechanism of action. And these slides are taken directly from the American Society of Hematology's presentation back in 2018. Next slide. So this is the design of the Medalist trial. It allowed patients by the WHO who had the ring sideroblast subtype, and they were randomized 2-to-1 to get luspatercept versus placebo. And this is an injection that's given underneath the skin every 21 days. Next slide. And so the primary endpoint, meaning what the primary goal for this trial was to try to decrease red blood cell transfusion. And their endpoint was actually very ambitious. It wasn't just trying to decrease it, it was to try to have red blood cell transfusion independence for greater than 8 weeks. Secondary endpoints was to try to do this for greater than 12 weeks. And other things that they wanted to look at was to see if they could change the actual red blood cell, the hemoglobin actual concentration level. Next slide. This was the baseline demographic data for the patients on this trial. 153 patients received luspatercept, and about half of that, 76 patients, got placebo. And you can see that all of the patients had the ring sideroblast subtype, and the majority of patients, sorry, not the majority, about half the patients, 43 to 44% of patients, had approximately greater than 6 units of red blood cells per week. And so that's a lot of red blood cells for a patient receiving this type of therapy. And a lot of the patients also had this mutation called SF3B1. And that's a mutation that we look for in this specific subtype. Next slide. Now, the reason why these slides look a little bit different now is that since 2018, Dr. Fernal has updated the clinical trials in last year at the American Society of 2019's annual conference. So what I'm going to do is I'm presenting the updated data because this is actually more updated than the old one by Dr. List. And what's really important to see here is that with the Medalist trial, that patients who received luspatercept, that approximately 47.7% of patients received and achieved transfusion independence, and that's compared to the placebo of 15.8%. And this was very statistically significant. And this transfusion independence was greater than 8 weeks. And prior to this, there wasn't anything available, so this is what's so exciting for us. Next slide. So, and this slide kind of breaks down for mean blood transfusion requirement prior. So you can see that there are a lot of patients that needed blood transfusions even greater than 6 units per week. And you can see that those in the luspatercept arm, 21% of those patients who needed greater than 6 units per 8 weeks had able to achieve transfusion independence. And that is something very remarkable with that. So in all cases, luspatercept had greater chance of transfusion independence. Next slide. This slide just shows the probability of transfusion independence and the duration of it. And you can see that the median duration of transfusion independence was approximately 79.9 weeks. And so this is updated. That's why they were able to see this over the course of greater than 1 year. So this is what's very exciting for all of us in the MDS community, that there's something that we can use in the lower risk setting. Next slide. Now, what we want to talk about is this is about treatment duration and cumulative duration of response. And we already talked about patients were on this for about a year, and you can see that their duration response for transfusion independence was about 79.9 weeks, which is very, very impressive. And the placebo is listed on the right-hand side here. Next slide. So, clinical benefit, patients that received luspatercept did derive a clinical benefit, and their duration of clinical benefit was also noted as well. So it was actually very, very impressive to see that there has been a benefit for both not only decreasing the transfusion needs, but there's in terms of the number of transfusions that needed, but also the duration. Next slide. Side effects are always something that we want to talk about, and this is what's presented on this slide. And you can see that overall, there were more side effects that occurred on the luspatercept arm, 41.8% versus the 30.3%. Most of the side effects are listed here, and I could tell you that when I've treated patients, the most side effect is that it's injection site pain, some overall fatigue, but otherwise, the most severe side effects, like grade 3 or more, were similar in both arms. And that's actually very exciting to see that the side effects were not that burdensome. In regards to safety, there was no higher risk of disease progression to a higher risk myelodysplastic syndrome or acute myeloid leukemia in either one of these arms. So this really just shows you that the luspatercept is actually quite a safe medication. Next slide. And this is the slide which I just discussed, was about disease progression. That in both slides, in both cohorts, patients who received luspatercept and patients who did not, the progression to higher risk myelodysplastic syndrome or acute leukemia was about the same. Next slide. All right. So, in summary of luspatercept is that longer-term analysis, which was just published by Dr. Fennell last year in 2019, showed that there was more luspatercept-treated patients that obtained transfusion independence at any time compared to placebo, and that's the first point. The second point is that luspatercept showed a greater cumulative length of benefit. There was more frequent side effects, but there was still decreased discontinuations over time. And what is really great now is that luspatercept is available for those patients with myelodysplastic syndrome with ring sideroblasts. There is a current phase 3, what they call the COMMAND study, and this is comparing luspatercept to just red blood cell growth factors in those patients who have low-risk MDS without this ring sideroblast subtype. So you can see that there are many different types of new trials that are coming from this for this low-risk setting. Next slide. So that's the only thing that I'm really going to talk about at length with luspatercept and also lower risk and intermediate risk myelodysplastic syndrome. I'm going to shift my focus now on higher risk myelodysplastic syndrome. And this is the same type of diagram that's presented by Dr. Sekaris and Dr. Cutler. And you can see that the main difference here is that if patients, the main branch point, I'm sorry, not the main difference, the main branch point that I want to very focus on is if a patient desires HCT or hematopoietic cellular therapy, and that is just an allogeneic stem cell transplant. So if a patient decides to proceed stem cell transplant, workup for stem cell transplant should be done as quickly as possible, and a referral to a stem cell transplant physician needs to be done. And that should be done in the higher risk setting. Now, if a patient declines stem cell transplant or doesn't have a suitable donor or does not want to proceed to stem cell transplant or is not a candidate for one, then different therapies can be offered. During the duration of my talk today, I'm going to be focusing just on the treatments that occur up to the point of stem cell transplant. I will have about 2 slides that touches on stem cell transplant, but that won't be the majority focus of my presentation. Next slide. So the big medication that we use is something called Vidaza or azacitidine. Now, this was the original trial, again, by Dr. Fennell, published back in 2009, that got azacitidine or Vidaza approved. So what they did was they took patients with higher risk myelodysplastic syndrome and they randomized patients between Vidaza, the azacitidine, versus conventional care regimens. What that means is that 50% of patients would get the azacitidine for 7 days every 28 days, and that's what we typically give right now, versus conventional care regimens, which was regimens that were available at that time. And that included supportive care, that included low-dose cytarabine, and standard induction chemotherapy. Next slide. So after randomization, patients were on the clinical trial. What they had were this overall survival kind of graph here. So the line in yellow were patients that received azacitidine, and the ones who received the conventional care regimen is that lighter blue dotted line. And what you can see here is that patients had a longer survival, meaning that they lived longer if they received Vidaza. On average, they lived about 15 months longer between, they lived a difference of 9 months longer compared to the conventional care arm here. So next slide. Based on that, they also looked at patients with blood count abnormalities. And those who received azacitidine, the azacitidine medication improved patients' blood counts no matter what it is. So how you interpret this graph is that any HI means any hematologic improvement, and you can see that Vidaza in this red color did better. And then all the other ones, dash E is erythroids, meaning red blood cell improvement, dash P is platelets, the platelet improvement, and dash N is neutrophil improvement. So although the neutrophils had the least amount of improvement, everything else had a major statistical significance improvement compared to conventional care regimens. Next slide. In terms of side effects, and these are grade 3 or 4, so these are major side effects that need to be reported to the clinical trial, is that the largest side effects that we see are the low blood counts, namely low white blood cells, low platelets, and low hemoglobin. And that's what's listed here on this slide. Other things like febrile neutropenia, which is an infection when your blood counts are low, and you can see that occurred a little bit more, which is 13% versus the 7% in those who did not receive Vidaza. And everything else was pretty much very, very little compared to the low blood counts and the febrile neutropenia infection. Next slide. So based on this clinical trial, what they were able to show was that there was a survival benefit of greater than 9.5 months. The time to acute leukemia was longer for patients who received Vidaza, meaning that Vidaza allowed patients to live longer in the myelodysplastic syndrome without going to acute myeloid leukemia. Transfusion independence occurred in 45% of the time versus 11% of the time, and that a complete remission occurred approximately 17% of the time. The median time to response was 3 cycles or 3 months, but by cycle number 6, you could see that 81% of patients improved. Because of this, this is what got the FDA approval for azacitidine, and this is why we do treat patients longer on azacitidine because it does take time, sometimes even up to cycle 6 before we see a response. All right, next slide. Okay, so the other hypomethylating agents that we have are is decitabine. So decitabine is the generic name. The trade name is Dacogen. And this is the phase 3 trial that was run by Dr. Kantarjian from MD Anderson Cancer Center in Houston. And this was published back in 2012. And so this decitabine is given also IV or injection. It's given for 5 days in a row. And the complete remission rate here was 15.7%. And you can see that the major toxicities were about the same, which was the neutropenia at 30%, the thrombocytopenia, and the anemia. So you can see that the cytopenias are about the same. However, fibroneutropenia, which is the infection with a low white count here, is a lot higher than what I just previously described in the azacitidine clinical trial. The complete remission was low, and based on this trial, there was some further workup that needed to be done before the FDA would allow the United States to use decitabine really as a standard for myelodysplastic syndrome. So there was further trials that needed to be performed, but after those trials, the FDA did eventually allow decitabine to be used for myelodysplastic syndrome. Next slide. All right, so these next few slides, I'm just going to quickly go over what happens when a patient gets treated with a hypomethylating agent and what actually happens with their blood counts. And so what I want to see here is this is what happens before treatment starts, meaning that a patient's blood counts will drop as the myelodysplastic syndrome progresses. And that occurs because normal cells are crowded out. And literally, you just have abnormal normal stem cells both in the bone marrow and the blood. So that's what we see on bone marrow biopsy and what we see in the very beginning. Next slide. All right. So when treatment gets started, treatment, quote unquote, cleans your bone marrow, and the blood counts will drop a little bit further, and therefore patients may receive and experience toxicities. Now, what I mean by toxicities, it just means you have lower blood counts, like lower hemoglobin, lower hemoglobin, neutrophils, and platelets, which can lead to increased fatigue, shortness of breath, and whatnot. And so you can see that your counts, your bone marrow is becoming a little bit less. On the top right corner of the slide here, this is a graph of someone's ANC, or absolute neutrophil count. So that's the infection fighting white blood cells. So you can see that someone starts off at 3,200, but once therapy is started, you can see that those neutrophils just drop pretty rapidly. And that's what we see. This dropping of these blood counts are absolutely normal, and we expect that, and that's what I cannot stress enough. All right, next slide. So as patients begin to respond, the bone marrow begins to recover, and it allows your bone marrow to have more healthy cells. And the blood counts should rise at that point, and when that occurs, MDS symptoms should also improve. Remember, this takes time, and that's closer to the cycles 4 to 6. All right, next slide. When, as the response continues, patients can be weaned from supportive care as robust response sets in. Next slide. So this dip is the thing that is most discouraging for both physicians and patients, because these toxicities are very hard, and we need to be better, meaning physicians need to be better at educating patients and also preparing patients on what to do during this time. Next slide. So this is the time where we need to work together. I need to work together with a patient, with a local oncologist if they're not seeing me, or a primary care doctor. So this is what I said. Cytopenias, blood counts will get worse before they get better, and we need to get through this time period together with supportive care. Patients will often need antibiotic prophylaxis, and we need to set good expectations with patients so that patients will understand that this is what's expected and we just need to be really careful. I list this down as a potential, which is dose modifications and delays. Now, when we are, meaning as physicians, when we're treating patients with myelodysplastic syndrome, I'm very regimented in the beginning. I do not like to have a lot of delays because these low blood counts are what we expect, and if we keep on delaying treatment, these stem cells get smart, these mutated stem cells get smart and can develop resistance to the treatment. So despite when patients may not feel as well, I want to be very persistent and continue to move forward as possible to get patients treated without many dose modifications or delays if that's possible with the patient. Next slide. All right. Now, many patients say, you know, I am in my upper 60s, 70s, or even 80s, and chemotherapy is just not for me. I see things that my grandmother, or I saw things on movies that chemotherapy looks really scary. And I do want to stress that chemotherapy is very scary, and it's not something to be taken lightly at all. However, the majority of patients with myelodysplastic syndrome are diagnosed in their 70s, and so we need to design, as physicians, chemotherapy that's gentler or gentle for patients that are in their 70s and 80s. So what they looked at was that same trial that I presented, but they looked at patients who were greater than 75 years or older. So they found that there was 87 patients that were greater than 75 years old, and they were basically higher risk or intermediate 2 risk. And Vidasa at that time still improved overall survival compared to best supportive care. So the 2-year survival rates, meaning patients being alive at 2 years, was 55% versus 15%, and that was very significant. Now, Vidasa was still well tolerated even during the first 2 cycles. So you could see that during cycles 1 and 2, there are a lot of patients who had low blood counts, but those low blood counts eventually started to decrease a little bit once things started to improve by cycles 5 and 6. You can see that the hardest thing that patients deal with is neutropenia, or low white blood cells. Next slide. So very, very briefly on allogeneic stem cell transplants. So allogeneic stem cell transplant means you are going to replace a patient's bone marrow, which has the dysfunction host system, with a normal, healthy donor. Now, this allows the donor immune system to destroy the abnormal and diseased MDS cells. So, in short, in the most generic of all terms, is to remove a MDS bone marrow and replace it with a healthy bone marrow that does not have MDS in it. Next slide. So, this slide is also made by Dr. Steensma, and it's based on data that was by Dr. Cutler and Dr. Sekris. And right now, if patients are greater than age 75, stem cell transplant may not be the best option, just because at that time, stem cell transplant may have more complications. So unfortunately, only less than 5% of patients with myelodysplastic syndromes really do go to stem cell transplant, despite it being, quote unquote, the only curative therapy. What our goal is, as a pre-transplant doctor like myself, is that I want to make sure that I get patients' blast percentage, that those leukemia cells, as low as possible. All stem cell transplant physicians at minimum will want a blast count of less than 10%. And because of how aggressive stem cell transplant can be, optimal timing is always discussed. And timing is really important. And so we don't want patients who are in very low or low risk patients to get stem cell transplant, because that is something that there's unneeded and unnecessary risk at that time. So what's important is to try to reserve this for those patients that have intermediate to high or high risk myelodysplastic syndrome to get transplant. And those who go through stem cell transplant and survive, that's approximately 40 to 45% of patients. They are officially cured for stem cell transplant, and they can do quite well. Obviously, the complication rate here is not something insignificant, so this is something that needs to be discussed with a stem cell transplant doctor. Now, this is based on older data, and there are newer techniques for stem cell transplant, and so talking to the stem cell transplant physician is going to be very important before you consider yourself not a candidate. Next slide. This summarizes stem cell transplant is that it is the only curative therapy, and like I said, timing is critical. Age is not an absolute contraindication. We need to consider everything, like other comorbidities, meaning what other medical problems does a patient particularly have. Next slide. So we're now going to move over to more clinical trials and more future directions of myelodysplastic syndrome. Now, so up to this point, what I've done is I talked about things that are FDA approved. All of the stuff upcoming now, just as a big disclaimer, is not FDA approved because it's undergoing clinical trials. Next slide. So the general term is that we do have to do better, because if a patient does not do well with the Vidasa or decitabine, we don't have many great options, and patients don't do well in that setting. So next slide. This one just shows you what happens, is that this was published back in 2011, and this shows what happens when a patient does not do well with Vidasa or azacitidine. So back in 2011, what they found was that when patients were, quote unquote, were told that Vidasa stopped working, the median overall survival, meaning the chance of living, was very low. And in fact, that average, on average, patients only lived 5.5 months after Vidasa not working. So, and this is why a lot of research has occurred in this area. Next slide. In 2020, there are a whole slew of myeloid mutations that can be checked via next-generation sequencing. Every year at our national meeting, there are new trials and new targets against these areas. And so what is just really staggering to really think about is that with all these different mutations, attacking one mutation is not good enough, because myelodysplastic syndrome can have multiple mutations, and they can have variant frequencies or amounts of the mutation present in a specific cell. So patients often ask me, well, I have this mutation on my DNA report. How come I can't just target that one only? Because that likely would not be enough. You need to target multiple, spots in order to cause what we need. Next slide. So immunotherapy has been a very hot topic, and it really started with my counterparts who does more solid tumor oncology, specifically those who do melanoma, lung cancer, and breast cancer and all. So immunotherapy, early results showed that as a single agent, nivolumab or ipilimumab, as a single agent, may do some sort of something with myelodysplastic syndrome. But when combined with Vidasa, there's better results. And so early form data showing that in that relapsed or failed setting of Vidasa and Dacogen, that the ipilimumab, there was still a response rate of even about 30%. And that is obviously very, very encouraging. So a lot of research is being done right now, specifically with ipilimumab and nivolumab. Next slide. There's a current trial called the ETCTN trial this one's from Dana-Farber, and it's run by Dr. Garcia there. And what she looked at is combining ipilimumab with decitabine. What this looks at is it looks at patients who has relapsed with a myelodysplastic syndrome after stem cell transplant, or even after 4 cycles of the Vidasa or decitabine. And so this is a very hard to treat population because after the hypomethylation agent, decitabine, we traditionally didn't have anything left. But this trial is showing some promising initial results that that hopefully we'll hear more from in the next year or so. Next slide. SGI-110 is a second-generation hypomethylation agent. This is a what we call second-generation decitabine. This was initially published back in 2013 when they took Dr. O'Connell from the University of Southern California, took 15 patients with higher risk myelodysplastic syndrome that all previously were treated, and about a third had response that lasted anywhere from a month to even several years. Next slide. So a follow-up study is being done, and this is published back in 2016. So this is called decitabine, and this is the second generation decitabine, like I already said. And what they saw was that they had 9 patients out of 56 that responded, and there was only 5 of them that had a complete remission. I know the numbers seem very small, but this is what these initial trials are showing. And this trial showed that there was a median duration of response of approximately 9 months and a median overall survival of an additional 6 months afterwards. Now, there are still ongoing trials with the second generation decitabine that's actively recruiting patients right now. Next slide. There is a current study called INSPIRE that uses the medication called rigosertib. Rigosertib is a agent that's given IV or oral that is used specifically under this setting. Next slide. What it does is, sorry, can you go back to that slide? It randomizes patients between rigosertib and to physician's choice. This current study is a phase 3 study, and what it did show was that early results had approximately, a third or even a fourth of patients that had some sort of positive, even a complete response after failing or progressing from a hypomethylation agent like Dacogen. And this trial has completed accruement already, meaning that it's closed to allow new patients on. However, we hope to get some more information later this year at hopefully our national meeting to know if that rigosertib may be submitted for FDA approval so that all patients with myelodysplastic syndrome can use. Next slide. There are other specific agents. There's been a lot of talk about venetoclax. Venetoclax is an oral agent that has been very popular in the acute myeloid leukemia setting. Now, in myelodysplastic syndrome, this is something that they are looking at currently with studies. What they looked at already and they know is that venetoclax has been used by itself. And using venetoclax by itself, it's not been as good as combining it with Vidasa. So there's a current trial right now that is trying to figure out how does patients do with venetoclax and azacitidine together, and it looks right now that it's a bit promising that there could be potentially a response rate of approximately 32% with this combination. So this is still very preliminary information that was just published or just presented last year in 2019, and we're waiting for the final results to be released to the medical community. So this combination is not FDA approved for myelodysplastic syndrome yet, but with clinical trials, we think that this may be a newer standard potentially in the year to come. This slide also talks about decitabine, which I already discussed. That's that second generation decitabine. There is an IV formulation, and there's also an oral formulation, and studies are being done with the oral formulation right now. there is also an oral formulation of azacitidine called CC486. This is still not FDA approved, and it's something being studied, and I don't have any prelim results right now. And then there's another medication called ASTX 727. This is a new medication that is being studied for higher risk myelodysplastic syndrome as well. Next slide. There are other targets that I just want to consider, and so let's move on to the next slide. So this, there's a medication called inacitinib, or IDIFA. This medication is an IDH2 inhibitor. This medication was recently approved in the past year for acute myeloid leukemia. And what it does, it goes into the actual the tumor cell itself, and it basically allows the cell to kind of destroy itself, and it's really kind of unique technology, and it targets a specific gene, this IDH2 gene. And so this was, the hardest part is that this gene is only occurring in about 5% of myelodysplastic syndrome patients. So it's a very small subset, but in this small subset, there was some positive responses, which are seen on this next slide. So Dr. Stein from Memorial Sloan Kettering back in 2016 presented this, and he was able to show that approximately 9% of patients achieved a complete remission, while overall response occurred in about 59% of patients. So that's very impressive in a very hard-to-treat population that had relapsed myelodysplastic syndrome. And you can see that there were improvements that were noted in blood count abnormalities. Next slide. There was a recent phase 1b/2 study of APR-246 in Vidasa. This is a very important study that was run out of Moffitt Cancer Center in Tampa. And the reason why this is very important was that this medication targeted specifically what we call TP53 positive or mutant myelodysplastic syndrome and acute myeloid leukemia. TP53 gene is a very poor prognosis gene. So patients with this TP53 gene typically don't do as well with standard chemotherapy. And so novel targets specifically against this TP53 is very important. And so this next slide will show some of the best responses. So what we see here is that in myelodysplastic syndrome, patients with this TP53 gene had a complete response rate of approximately even as high as 67% and 80% in those with acute myeloid leukemia. This is incredible because with just Vidasa by itself, historically, this patient population would only receive a 20 to 30% complete remission rate. So you can see that there's a lot of things that are exciting that are occurring with clinical trials. Next slide. Actually, just due to timing, I'm going to skip these next few slides. What these next few slides talk about is this new diagnosis or this new entity called CHIP, which is clonal hematopoiesis of indeterminate potential. This is what even some patients describe as a pre-MDS state. So if a patient already has a diagnosis of myelodysplastic syndrome, they're not going to have a diagnosis of CHIP because this would occur prior to it. And so in the interest of time, I'm just leaving all of this available so that people can have it for their own reference. Let's get through, yes, to the conclusion. Next slide. So again, what we want to do and what we talked about is if there's any symptoms that are concerning for low blood counts, we want to go through clinical history, and then if there's high enough suspicion, a patient should be referred over to a hematologist. My rule of thumb, and I tell all my patients this, is that if you have 2 or more low blood counts, meaning if you have a hemoglobin and a platelet that's low, or a platelet in white count that's low, that means that this patient should be referred over to a hematologist right away, because it's very important that multiple abnormalities are looked at very quickly versus letting a primary care doctor trying to figure this out over several weeks to months. Next slide. So, in conclusion, myelodysplastic syndrome is the most common myeloid malignancy, and some of the survival curves are even as scary as those of lung cancer. However, there's a lot of work that has been done and that's continuing to be done. Workup with cytopenias need to be done by the primary care doctor. If any questions are referred to a hematologist. Therapy for lower risk myelodysplastic syndrome addresses the specific low blood counts. In some cases, we'll talk about the karyotype abnormalities. However, therapies for the higher risk settings, which we already talked about, should occur immediately and can prolong survival. Obviously, there are some disclaimers and there are some asterisks, and so you just need to talk to a primary care doctor on that. Treatment does take time, so please be patient. And the next regulatory frontier, which we talked about, is in that relapse refractory setting, both in the lower and higher risk settings. As I already attempted to talk about, is that there are a lot of potential markers and clinical trials that are available out there. But what I would recommend for all patients with myelodysplastic syndrome is to go to a center that offers specialists who specifically looks at myelodysplastic syndrome, and also that has clinical trials available, because just asking these specific questions and getting a second opinion would make complete sense and can help you with a overall in the disease course. Next slide. I just want to thank everyone for listening today. I want to thank my team at the University of Virginia, the Leukemia and Myelodysplastic Syndrome team, and specifically the Aplastic Anemia and MDS International Foundation for having me today. And of course, to all our patients and families, I wouldn't be here and we wouldn't be doing what we are doing what we love to do if it wasn't for our patients and family. So thank you very much. I hope that this was helpful, and I'm sorry for squeezing a lot of things in just about an hour.
Thank you so much, Dr. Keng. We do have a few questions. Our first question is, if luspatercept maintains your hemoglobin count at the current level, does it make sense to first raise a low hemoglobin count through blood transfusions before receiving luspatercept?
So the way that luspatercept works is that, I'm just trying to read the question at the same time, is that it's very important to focus on the blood transfusion component, because that affects quality of life, and that can decrease the amount of iron overload potentially. So I wouldn't hold off on getting luspatercept. So if a patient meets and has a subtype of ring sideroblasts and are receiving blood products, this is the perfect setting for this is the perfect setting for luspatercept, and I would recommend luspatercept and not wait to raise the hemoglobin up any higher first.
Thank you. Can luspatercept help with raising low platelet counts?
So it was not studied that way, and that was not, so the study was not powered to look at other low blood counts, namely the low platelets and also neutrophil count. What I can tell you in clinical practice after giving luspatercept, what I have seen is that when the red blood cells do increase, patients do feel better from a quality of life standpoint. And I have seen, obviously this is just in clinical practice and experience, that I have seen some increases in both platelets and neutrophils. But this is not well documented in the study, and we're still waiting for the study to be released to us.
Thank you. Does dysplasia change with treatment?
Yeah, so dysplasia could definitely decrease with treatment, and it can increase with treatment. So when patients get chemotherapy, the goal is to decrease the amount of dysplasia that's seen and to decrease those bad blasts, those leukemia cells that we already talked about. So our hope is that dysplasia can decrease from that setting. However, looking at bone marrow biopsies quite often, what I've noticed is if you do a bone marrow biopsy during chemotherapy itself or immediately right after, meaning like a day or two afterwards, you may actually see some normal cells looking a little bit different too, just because of the recent chemotherapy that was given. So dysplasia should basically potentially get better with treatment, but the timing of the bone marrow biopsies is also very important.
Thank you. Do gene mutations stay forever, or do they change with hypomethylating agents?
So the answer to that is yes and yes. So gene mutations can definitely change, and I've seen gene mutations go away and then come back. I've seen new mutations pop up, because what we described earlier was that myelodysplastic syndrome is a very heterogeneous disease, meaning that a lot of things may not be present in the beginning. There could be gain of mutations, or other mutations that were very low level may become more problematic later. So things can go away, but then unfortunately, when things go away, things can also come back at the same time.
Thank you. Can you explain sideroblast versus ring sideroblast?
So sideroblast versus ring sideroblast are essentially the same thing. I think it's just the terminology that's being used specifically. So what we're talking about here is myelodysplastic syndrome with ring sideroblasts or sideroblasts. And so ring sideroblasts are basically red blood cells, and they have extra material inside. And what's scary is sideroblast has the word blast inside, but these are not leukemia cells. These are just red cells that look and have some extra material that look very specifically and stain specifically. And to be very honest, when it's with the SF3B1 mutation that we talked about before, there is actually a positive prognosis, because it can be quite receptive with luspatercept, meaning it can be, luspatercept can be used and it can work well in that setting. And also, patients generally don't transform as worse with the ring sideroblast subtype.
Thank you. There's often discussions regarding low risk versus high risk MDS, but if you're an intermediate risk, should you be looking more towards high risk treatments?
That is a fantastic question, and that's the subject of a lot of debate right now. But what I already said was this: the scoring system is not perfect by any means, and so what happens is that some intermediate patients should really qualify for low-risk trials, because you could be higher risk just by a low red blood cell count or something like that. But some patients, intermediate risk, should be really considered higher risk. So I think it's an individual case-by-case basis, and clinical trials will specifically spell that out. So to see if you're eligible for a clinical trial or not, one would need to read the inclusion and exclusion criteria very carefully and talk to the specific physician. But to answer this question, you can be conservative and look at the higher risk settings, but I would talk to your oncologist and then specifically ask, should that person be considered lower or higher risk?
Thank you. Does luspatercept make sense for somebody who is not yet transfusion dependent, but is having lowering counts?
So I think that it depends on how low your hemoglobin value is, to be very honest, because this is a growth factor, and just because your hemoglobin is, 12 and it's not completely normal, I would not recommend luspatercept in that setting. I would wait for the wait for the hemoglobin to be a little bit lower. If you're not receiving red blood cells, we won't know if it's really working if your hemoglobin is still very high. And if you don't have any symptoms to give medications, you could potentially get symptoms with it. So in my practice, I typically would ask how patients, if they have symptoms and what symptoms they are, if it's associated with the low red blood cells, and then have a risk-benefit ratio discussion of whether if luspatercept makes sense in that setting.
Thank you. How long do you typically have red cell transfusions before getting iron overload?
That is also another fantastic question. What we typically say is you need to have a lot of red blood cells. You would need to have received red blood cells almost once or twice monthly, like 2 units, like every 2 weeks or so, for approximately a year. And so after that year standpoint, if you're still receiving that much red blood cells, there can be concern for iron overload at that setting. And then that is a discussion with your oncologist to decide whether iron chelation or removing the excess iron actually makes sense.
Thank you. What in the bone marrow produces cancerous stem cells?
I would say that cancerous stem cells can be caused by that what we talked about, the intrinsic or extrinsic type of factors, meaning that if the bone marrow doesn't just all of a sudden produce cancer cells because it's not designed to do that. But if there are outside factors that occur or inside factors like your genetics or some sort of drugs or drugs would be external, but if there's some other factors within, then what would happen is that if your cells are not able to, meaning your immune cells are not able to compensate and remove these bad cells, then those cells will continue to produce and have those more cancer cells leading to myelodysplastic syndrome.
Thank you. What is the benefit of venetoclax and ARAC?
So right now, venetoclax and ARAC, which is cytarabine or a low-dose cytarabine, is a currently approved combination therapy for acute myeloid leukemia right now. It is not approved in myelodysplastic syndrome. And so there are ongoing studies on this right now, and I cannot tell you if there is a benefit or not because we're waiting for that to come. But it is approved in acute myeloid leukemia, and I believe in the course of the next year we'll hear more about whether it's going to be helpful in myelodysplastic syndromes.
Thank you. Can patients be treated with Dacogen for low platelet counts?
Dacogen is a hypomethylating agent, and so it is reserved for those who have higher, like intermediate to high or very high risk myelodysplastic syndromes in my mind. If someone, it's really hard to know because that's a fully loaded question. Without knowing all the background information, I really can't say much more. But if a patient truly only has low platelets, the thrombocytopenia, there are other easier options that are available other than decitabine. Decitabine is an IV chemo and should be reserved in the more higher risk settings. But if a patient does have higher risk setting and has inadvertently thrombocytopenia, then decitabine would be okay.
Thank you. You had mentioned that stem cells can develop resistance to treatment if there are delays. Can Dacogen be effective at once every 3 months if they have toxicity with treatment every month?
That's another great question. I think that it really depends and it depends on what type of response was already obtained with these chemotherapies. So I am well aware that, decitabine or Vidaza should be given every 4 weeks and should be given on time, like I said earlier, to try to give the best results. What's very difficult is that, there could be side effects like lower blood counts or fatigue, shortness of breath, something like that. And the times that I dose reduce or I change the cycles would be dependent on a bone marrow biopsy after 4 to 6 cycles telling me that a patient has done well and has just too much drug in their system. So before just saying giving decitabine every 3 months, which is an awfully long interval in between, I would want to make sure that that particular patient would have a good response that's documented and to find the least time interval in between to give these medications out. I would just definitely talk to your doctor about that. There are case reports that some patients can tolerate very minimal doses, like every 3 months out, and do really well. And it's just a one-on-one individual decision.
Thank you. We have time for one more question. Are hypomethylating agents considered successful if they only raise the platelet counts and not the red blood cell or white blood cell counts?
This is a great question, but also really tricky, because it depends on what you describe as successful. Because if you're talking about getting into a complete remission, then the chemotherapy is not successful then, because remission means that your bone marrow needs to have a completely no more blasts, and your blood counts need to be completely recovered. Now, when you're if you just have an incomplete hemoglobin or platelets or whatever you're saying, but if the quality of life is good, then I consider that very successful, in that I need to figure out what is the best way to make those other values better. Is it because the drug is too strong? Do I need to dose reduce or change something? Or do I need to think of a better supportive regimen? So it can be successful, absolutely, with not normal counts. However, it's really important to make sure we understand what the goals were of treatment prior to everything.
Well, thank you so much, very much, Dr. Keng, for taking the time today to share your expertise with all of us. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to answer your question today, you can send it to us anytime in 3 ways. Send an email to help@aamds.org, call the helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family, as we have for the past 36 years. This concludes today's program.